My name is Danny Meijer. I'm a PhD candidate and a resident in urology in the Amsterdam UMC in Amsterdam, the Netherlands. And I'm doing my research since 2 years now regarding PSMA-PET scan in prostate cancer together with the Netherlands Cancer Institute. In the present study, we aim to externally validate all available predictive nomograms for the presence of pelvic lymph node metastases in patients undergoing radical prostatectomy. So those are the Briganti 2017 and the Briganti 2019 nomograms and the MSKCC nomogram from New York. And we subsequently aim to add the findings on PSMA-PET to these models, so the lymph node status on PSMA-PET. And what we found was that the predictive performance, defined as the AUC, of all 3 predictive models increased significantly when we added the findings on PSMA-PET to these models. So this guides us that PSMA-PET may be a future candidate for a novel modern predictive nomogram. Yes, unfortunately, I do not have those numbers because in the present study, we assessed the value of PSMA-PET in the detection of pelvic lymph node metastases in all patients who underwent radical prostatectomy and extended pelvic lymph node dissection. So we did not look at the patients who did not undergo surgery because of metastatic disease on PSMA-PET. A colleague of mine in our research group is investigating that right now, but currently I do not have those numbers yet. Yes, that's a very interesting question. I think in the Netherlands, we perform PSMA-PET in primary staging in patients with intermediate and high-risk prostate cancer. And the prediction of pelvic lymph node metastasis is primarily performed with the nomograms, but the gold standard verification is the extended pelvic lymph node dissection. And due to the moderate sensitivity of the PSMA-PET, I believe the primary value of this study will be in the intermediate risk patients, because patients with high risk prostate cancer usually have an increased level of the nomogram, so an increased chance of having the lymph node metastasis, and that PSMA is not able to lower that chance below the cutoff values. So I think that's the primary aim of this study, to investigate in which patients an extended pelvic lymph node dissection cannot be done. Yeah, that's an interesting question, but I do not really think that that will be the case. Of course, potentially MRI has the potential to better visualize a regional lymph node metastasis because of the higher sensitivity than the CT scan. But all the nuclear medicine physicians who report on the PSMA-PET scans primarily report on the PET scan and the uptake of the PSMA tracer in different anatomical lesions. Afterwards, they select if they can find some anatomical correlation on CT or on MRI, but primarily their reporting is based on the PET scan and not on the concomitant imaging. So potentially MRI is better, but I don't think it will make a huge difference in primary staging for these patients.